All right, so our lecture for today is going to be about GU surgery through anticipation and preparation. It's designed to help you as surgical technologists think ahead rather than react during procedures. The goal is to improve efficiency, safety, and coordination. Also, for you to learn about these different procedures during this course. This playbook is based on established curriculum standards and real procedural workflows. GU surgery is divided into four main areas. You're going to have your kidney, adrenal, ureter, bladder, prostate, and penile testicular. Each area has unique procedural goals such as filtration, storage, outflow, or reconstruction. These categories help guide setup, instrumentation, and workflow. Understanding them allows the surgical tech to anticipate needs more effectively. There are three main surgical approaches. Technically, there's four, but I kind of group lap and robotic together. And then you have open and endoscopic. Each surgery emphasizes exposure and vascular control, while endoscopic procedures rely heavily on fluid management and visualization. Robotic and laparoscopic approaches require advanced setup and precise coordination. Each modality demands different priorities from the surgical technologist. Three key principles guide GU surgery: fluid management, specimen tracking, and tissue preservation. Maintaining proper irrigation ensures clear visualization and safety. Accurate specimen labeling is critical due to fragmented issues. Protecting delicate structures is essential for patient outcomes. This slide compares a nephrectomy and a pyelolithotomy workflows. Nephrectomy involves access, hilum control, and full organ removal, while your pyelolithotomy focuses on stone extraction and reconstruction. Proper positioning and setup are essential for both. Anticipating vessel ligation and having instruments ready is critical for safety. This procedure begins with pneumoperitoneum and exposure of the kidney. The most critical step is controlling the renal hilum using clips or a stapler. The final phase involves specimen removal using a retrieval bag. Strict timing and discipline are essential to avoid complications. This is going to be a kidney removal, a laparoscopic kidney removal you see here. Kidney transplant surgery has two phases. You have vascular anastomosis and urologic reconstruction. Blood flow is restored during reperfusion, which requires careful monitoring. The procedure then transitions to ureter connection and closure. Anticipation is key during clamp release and instrument changes. This procedure requires careful handling due to the risk of tumor rupture. This is going to be a Wilms tumor. This is a pediatric case you mostly will see. Steps include exploration, vascular ligation, and in-block resection. Maintaining patient temperature is especially important in pediatric cases. Gentle tissue handling and preparation for specimen transfer are critical. Endoscopic procedures rely on proper setup of scopes, cameras, and irrigation systems. The workflow includes scope assembly, urethral access, and guide wire placement. Continuous fluid management ensures visibility. Maintaining sterility and avoiding premature opening of supplies is essential. This surgery involves three phases: extirpation, diversion, and closure. After removing the bladder, the surgeon creates a urinary diversion using bowel. A major transition occurs between phases, requiring equipment changes. Supplies should only be introduced when the surgeon commits to the next phase. The MMK procedure is used to correct bladder support issues. It involves retropubic dissection, identifying the bladder neck, and placing sutures. Proper bladder decompression is required before incision. Timing of suture preparation is critical to workflow. There are three main approaches to a prostatectomy: TURP, suprapubic open, and robotic. Each uses different techniques such as electrosurgical resection or blunt enucleation. Bleeding control and irrigation are key concerns. The robotic approach requires precise suturing and coordination. There's also a new method that uses water ablation for prostatectomy that a lot of hospitals are starting to get into. TURP involves removing prostate tissue using a resectoscope loop. The process includes resection, chip evacuation, and hemostasis. Continuous irrigation is required for visibility. Proper Foley catheter placement completes the procedure. Your laparoscopic prostatectomy with a robot. This procedure includes docking, dissection, venous control, urethral transection, and anastomosis. Patient positioning and robotic arm placement are critical. Bleeding control during venous ligation is a key moment. Instruments must be ready before major transitions. Prostate alternatives. This slide covers open enucleation and brachytherapy. Open surgery involves removal of prostate tissue through a cystotomy. Brachytherapy uses implanted radioactive seeds. Both require careful preparation and strict safety protocols. Procedures include circumcision and penectomy. The workflow involves marking, excision, hemostasis, and closure or reconstruction. Bleeding control is an immediate concern. Instrument readiness depends on the specific procedure before being performed. This slide focuses on hypospadias and epispadias repair. Both require straightening of the penis and reconstruction of the urethra. The process includes flap creation, correction, and layered closure. Precision and organization are essential for success. This slide reinforces the importance of anticipating surgical steps. Recognizing patterns allows the technologist to prepare instruments ahead of time. Efficient workflow reduces delays and improves patient outcomes. Consistency and organization are key. This slide highlights safety alerts and critical thinking in GU procedures. Awareness of high-risk moments helps prevent complications. Communication with the surgical team is essential. Preparation and vigilance ensure smooth operations. This slide emphasizes integrating different surgical approaches and techniques. Understanding when and how transitions occur is crucial. The technologist must adapt quickly between phases. Mastery comes from recognizing patterns across procedures. You'll see here your Mayo stand for a GU. A lot of times you're just going to be using a back table instead of having a Mayo stand if it's a smaller cysto case. Mastering GU surgery requires anticipation, organization, and technical knowledge. Surgical technologists play a critical role in maintaining efficiency and safety. Applying these principles improves outcomes across all procedures. The ultimate goal is proactive, confident surgical support. You'll see here, these are a lot of things with GU. You have your fluid, which is a really big deal. Irrigation has to continue. You have to monitor it and watch it. You'll see track your fragments. So anything coming out, typically you're going to have your screen where you're going to scoop your specimens out of, the doctor will. You're going to protect your outflow. Your stent placements are a big deal. Catheter is a big deal because you want to decompress that bladder. And your weight to open. From penile implants to ureteral stents to radioactive seeds. Never open expensive or sterile critical items until exact measurement and surgeon commitment are confirmed. Okay, we're going to continue on with robotic surgery. Just a little bit of information here for you for robotics. This is becoming more and more prevalent. Traditional surgery is limited by human factors like tremor and restricted wrist movements. Robotic systems overcome these limitations through tremor filtering and advanced articulation. They also provide 3D high-definition visualization for better depth perception. This shift significantly improves surgical precision and control. This timeline shows the evolution of surgical robots from early systems to modern platforms. Early systems like Puma and ASOP laid the groundwork for robotic assisted procedures. The introduction of Da Vinci systems marked a major turning point in surgical adoption. Today, robotic surgery is widely used across multiple specialties. Most are going to be your Mako systems and your Da Vinci robot. There are multiple robotic platforms available, each with unique capabilities. The Da Vinci system dominates many specialties with multi-arm configurations. Other systems like Versius and Hugo offer modular or flexible designs. Understanding these platforms helps determine the best tool for specific procedures. You're going to see a lot of these different ones, and you're going to learn how to use different ones. You're going to learn how to drape different ones for all different specialties. A robotic operating room consists of four main components: the surgeon console, patient cart, bedside assistant, and a vision cart. The surgeon operates remotely using immersive 3D controls. The bedside assistant manages instruments and assists during the procedure. Coordination between all components is essential for success. As a tech, you'll be up by the table with your Mayo stand with all your other alternate instruments, and you may be able to change them out. Some places only the first assist or the PAs can change them out. The surgeon will be in the room, but in the corner on the console you see here. And then you will have your tower with your screen so everyone in the room can see what's going on. Robotic surgery training follows a stepwise progression from basic to advanced skills. It begins with patient-side training and moves into virtual simulation. Next, trainees practice in wet or dry labs before performing real procedures. This structured approach ensures safe and effective skill development. The GEARS framework evaluates robotic surgical skills across 6 domains. These include depth perception, dexterity, efficiency, and control. Surgeons are scored from 1 to 5 in each area. This system helps standardize training and measure competency. This is just a little background so you guys can see what does a surgeon go through before actually being able to use the Da Vinci robot. It's not something they're just allowed to use whenever. The procedure begins with proper patient positioning. This is for a hysterectomy. This is becoming more and more prevalent to use. A Foley catheter is inserted to decompress the bladder. A uterine manipulator is placed to assist with positioning and traction. Pneumoperitoneum is then established to begin the procedure. Ports are placed carefully to allow optimal robotic arm movement. Proper spacing is critical to avoid instrument collisions. The patient cart is then docked to the trocars. Accurate placement ensures smooth workflow throughout the surgery. The surgeon uses robotic instruments to divide ligaments and identify key structures. Continuous visualization of the ureters is essential to avoid injury. The assistant plays a key role in suction and bleeding control. This phase requires precision and constant awareness. Can see here on the thing your broad ligament and your cardinal ligament, and then you can see here how they have the trocars. The uterus is removed either vaginally or with a specimen bag. The vaginal cuff is then closed using robotic suturing technique. After closure, the robot is undocked and final checks are performed. Proper closure ensures healing and reduces complications. This is going to be for that prostatectomy we were talking about during GU surgery. The patient is placed in lithotomy and steep Trendelenburg position. Special attention is given to padding and nerve protection. Again, this is only during robotic. During a regular one, you're going to be in lithotomy. Arms are secured to prevent injury during robotic movement. Proper positioning is critical for both safety and access. The abdomen is prepped and pneumoperitoneum is established. Trocars are inserted with precise spacing to allow robotic access. The robot is docked and the surgical field is prepared. Equipment organization helps prevent delays or complications. So for you as a surgical tech, you want to keep everything where you know where it's at so that you can switch things out rather quickly. The surgeon carefully controls the dorsal venous complex to prevent bleeding. Nerve sparing techniques are used to preserve function. The prostate is then mobilized and separated. This is one of the most technically demanding phases. can see here the prostate around here, and then you have your urethra into the bladder. The bladder and urethra are reconnected using precise suturing. Leak testing ensures the connection is secure. A Foley catheter is placed to support healing. Final instrument checks and undocking complete the procedure. So that's just a couple of examples of robotic. You can do robotic cholecystectomy, robotic appendectomy, robotic hernia repair. So there's a lot of different robotic procedures you can do. That's just a couple of examples for you. Robotic systems require significant upfront investment and maintain costs. However, they can reduce hospital stays and improve recovery times. Data shows shorter length of stay for robotic procedures compared to open surgery. These benefits can offset some of the financial burden. Robotic surgery offers improved outcomes like fewer complications and faster recovery. It also reduces readmission rates and improves patient satisfaction. However, risks include mechanical failure and lack of tactile feedback. Balancing benefits and risk is essential in clinical decision making. This slide reinforces a balance between technology and surgical skill. Robotic systems enhance performance but still require expert control. Proper training and awareness are essential for safe outcomes. Technology should support, not replace, clinical judgment. Robotic surgery represents the future of precision medicine. Mastery requires understanding both the technology and surgical workflow. Continuous training and evaluation are key to success. Ultimately, the goal is safer, more effective patient care. So that's it about GU and robotic surgery. These are kind of quick, but it gives you an idea of both of these. In your book, you're going to see a lot more procedures with these. Cysto can be really basic up to really complicated, and robotic, same thing. You can have very simple robotic cases up to very complicated cases. But you're going to end up seeing all of them, and you'll see the differences in them. So thank you very much. See you next week.